it definitely contributes to survival. The problem is that every time you talk about studies of that magnitude, then you're looking at perhaps a selection bias. Why was the Desferal utilized? Why, you're probably utilizing the oral agents for people who have better performance status. Maybe that's a reflection of why their survival is a little bit better. So it's difficult, but I think it would be nice to demonstrate improvement in organ function, by the use of iron chelation, which I tend to think that is the holy grail of iron chelation therapy.
So you talked about organ function, and one organ function that improves is often the bone marrow function.
Yes.
Right? The EPIC trial, we saw that. There was some in the USO3 trial. So I think the data show that maybe up to 20% of patients can have erythroid responses and even transfusion independence. And I think it's important to mention that these take time, and they take about approximately 3 months or so. So if you're not persisting with the chelation, you probably don't get the benefit. What's your view on improvement in hematopoiesis with iron chelation?
I think it should not be a goal, and that may be a side benefit of the therapy. We don't have any real prospective data addressing specifically these questions, mostly retrospective data that we have. But it's several studies, several independent studies. There was Italian studies, European studies, the US study, basically having the same conclusion that we may have some modification transfusion requirement for this patient. One thing also to keep in mind is usually this response seems to be pretty short-lived. So we can't just rely on iron chelation, and I think that should not be something that we stress for the patient as potentially one objective of the treatment.
I totally agree with you. I think I usually step back, and I think you have to have that benefit-risk discussion with the patient. So basically, there is some evidence that there is benefit of iron chelation. We know that iron overload is probably the same whether it's thalassemia, MDS, or myelofibrosis. So iron overload over time will cause problems. But there are some risks for those medications, toxicities that we have to keep an eye on, and you are doing that balance, and you present that story for the patient and decide. The patients I usually think of offering iron chelation, I agree with Thomas, like I would not be aiming for hematological improvement, but if somebody has lower risk disease, that in my risk assessment that those patients are gonna have 8 to 10 years survival, I think iron overload is gonna be an issue. So I think of considering that patients that had been through several lines of therapy and now are just on best supportive care, transfusions all the time. But I also actually take sometimes the window when the patients respond to treatment. Let's say somebody came and they were like 2 years getting transfusions, and now we put them on a trial or lenalidomide and they had a good response. That could be a window of opportunity where you actually do better iron chelation. Now, if somebody has a very high risk disease where unfortunately the disease factors are gonna dictate the outcome in a short time, I don't think those patients will benefit from treatment, and the risk of adding toxicity to whatever you are treating is gonna be more.
Definitely, and I want to clarify one issue just to make sure that people don't leave with the wrong idea, is that hematological improvement with persistent chelation is a proof of concept that actually eliminating the toxic material from the bone marrow or adding onto it is what preserves organ function. So I mean, it's more of a building block of making sure that those patients are monitored adequately and taken care of, in that type of fashion. So obviously the goal isn't to have hematological improvement, but it's intriguing to see that extended chelation can result in that in a small number of cases, which is very interesting.
You also briefly touched upon that group of patients who may not be very transfusion dependent but may have ineffective hematopoiesis and erythropoiesis who may absorb more iron. And we do see this in some of the ring sideroblasts type of MDS.
And in most of the patients, actually, like the data presented by Dr. Guillermo Sanz a few years ago when they presented on the serum ferritin and the tremendous increase in risk of mortality if the serum ferritin are high. When I asked him about how many of those were like up front, 1/3 of the patients would have serum ferritin more than 1,000 up front. Again, we have to be cautious a little bit because this could be inflammatory marker, not only just hemochromatosis. And you are right, obviously, there are subtypes of MDS that naturally will have better outcome, like the ring sideroblast, the deletion 5q perhaps, that will have longer survival on and off blood transfusions that over time will build blood transfusions. So
I think as a particular subset, I
Right.
think
Right.
we have to look at them kind of separately, and there I think iron chelation is much more important in that group of patients.
What can be debated is there any role for iron chelation in high-risk patients? For
Right.
example,
Right.
for the small subgroup of patients for which we consider transplantation
Right.
as a potential consolidation treatment, and that's maybe debated. We don't have any real data on that. But based on the transfusion dependency of the patient before hypomethylating agent therapy or other, for some I may consider in that case iron chelation. If I'm
I think prior to transplant, or if you really are planning on transplanting that patient, that is a higher risk patient, which is a candidate for chelation therapy.
I must say that this is not, it would be totally off-label.
correct.
Because, you know, for platelet count less than 50,000 or into a high-risk disease, it's not approved.
So I think if you step back and look at what are the data, obviously there are some data suggest that ferritin level peri-transplant that does affect outcome in terms of like even increased infection, graft versus host disease. So the challenge sometimes is that window of opportunity you have, because you see those higher risk patients, you are going to move to transplant directly, and you don't have significant time. Most of the time we end doing iron chelation actually after the transplant in some of those patients. But every now and then you would see a patient that are lower risk on the younger age, that you know that after 2 or 3 lines of therapy you are going to be thinking of transplant. So those are actually, I keep also more eye on iron chelation, that this is lower risk patient, but after 3rd line therapy failure, I'm going to be taking this patient to transplant. So I have a window of opportunity now to do the iron chelation. So that's a patient I think even more than a higher risk.
And I
not
couldn't agree.
Based on the label or not.
I couldn't agree more with you on that one, because this patient who needs to go to transplant at the time of progression, you don't have a lot of time to optimize their iron parameters. So.